Okay, just let me know.
Al doctor Mariano Dioca, médico del Servicio de Oncología Digestiva del Instituto Ángel Rojo en Buenos Aires, Argentina, quien nos va a hacer una actualización de los temas más importantes en los tumores del estroma gastrointestinal. Así que, doctor Dioca, muchas gracias.
Bueno, buenas tardes a todos. Mi nombre es Mariano Dioca, soy médico oncólogo especialista en tumores digestivos del Instituto Ángel H. Rojo. En este ratito vamos a aprovechar a repasar un poco un pantallazo general sobre la enfermedad y ver algunos avances interesantes que se han hecho recientemente. Como sabemos, la epidemiología...
There is a doctor speaking about GIST epidemiology, and there's a lot of coupling, so I do not know if you can hear correctly. I hope you do. And we analyzed the algorithm from micro GIST or GIST, the submucosal tumors less than 2 centimeters could be left for observation. 2 to 4 centimeters are left for laparoscopic resection, more than 5 conventional surgery with open resection. That are significant, up to 50% will recur or metastasize. A 5-year survival rate is 30 to 40%. GIST is the model that are resistant to conventional chemoradiotherapy, and with the introduction of TKI inhibitors, the course of the disease has changed. The clinical presentation is very heterogeneous. You can see asymptomatic and incidental findings up to large masses, exophilic masses that you can see in the gastric area. 60% of patients with primary tumor in the stomach, 25% small intestine, 8% other, mesenteric retroperitoneum, 5% colon rectum, and less frequent areas such as esophagus in 2%. The diagnosis, microscopic sometimes it is a challenge. We see different patterns, spindle cells, mixed cell types, and epithelial type. From the old algorithms to be able to stratify the patients, we have this old scale from Fletcher, the risk from very low to high, very low risk, low, intermediate, and high risk according to tumor size. And then the scale from Mietinen and Lasota changed this to the new diagram that is widely used. Molecular classification, nevertheless, is a very important point. We have different frequent mutations, such as in exon 11, and less frequent that occur on exon 9, and mutations of PDGFR alpha or familial GIST, pediatric GIST associated to Carney's disease. From the analysis from Cabos, we can see the expression of the different mutations on the different exons. Of course, the mutation on exon 11 is the most frequent one, 60%. And what is interesting is that the different types of mutations have different sensitivities to imatinib, different response rates, and the different progressive disease, progression disease control, and the mutation D842V of the PDGFR alpha does not even respond to imatinib. So there are different sensitivities to respond to imatinib, such as the exon 9 hit mutation that is sensible to imatinib. We will speak about this later on. And we all know the benefit of adjuvant imatinib use. We have the ACOSOG trial, phase 2 trial, that's its impact of progression-free survival, but not in overall survival rates. And later on, the Scandinavian trial showed benefit of 3 years versus 1 in those patients with risk, moderate to high risk. We already have efficacy studies and phase 1, 2, and 3 on efficacy of imatinib. Tumor regression is very high, 50 to 70%. We always speak about sensitive mutations, progression arrest, and progression disease, rapid regression of symptoms in 80 to 90% of the patients that will improve of their symptoms, and progression-free survival at 1 year of approximately 17%, and progression-free survival up to 3 years reach 30%. Very interesting. When there was an attempt to assess a higher dose of imatinib as a first line of treatment, we see this blank trial published in 2008, 400 milligrams per day without evidence of response, progression-free survival, P of 0.37. And the role of stopping imatinib and initiate at the time of progression of disease, this resulted in a rapid clonal repopulation and rapid disease progression. This published is very well known by all of you. The truth is that independently of what you reach in terms of response rates, being best response, partial response, this has not significant differences in global overall survival rates, independent of the results of the response. The patients will benefit in the same manner in terms of overall survival in comparison to the patients that progress, that have disease progression. The question is there a role for first-line treatment imatinib, 400 versus 800 milligrams, the North American trial versus the European isolation trial, where there are no statistically significant differences in comparison with historical controls prior to the introduction of imatinib, and those patients that have mutations that are relatively insensitive, those that in exon 9 will truly benefit or use high doses of imatinib, 800 milligrams versus 400 milligrams, green versus red, respectively, in patients with exon 9 mutation. To summarize, 800 milligrams per day imatinib significantly benefit those patients that have KIT positive mutation on the exon 9 mutants versus other genotypes that are independent predictors for poor progression-free survival, male gender, poor performance status, low baseline hemoglobin level at the start, high baseline absolute neutrophil count, or bowel origin of GIST. When we speak about second-line treatment, and there are many years from the phase 3 trial that randomized intolerant patients to imatinib or have failed to imatinib treatment, submitted to sunitinib treatment, 2 weeks on, 4 weeks on, 2 weeks off, up to the disease progression, and then crossover of the patients that were in placebo arm to the sunitinib arm to an active treatment. The primary endpoint was progression-free survival, and we can see a statistically significant difference favoring the use of sunitinib 27 weeks rigorous himself in comparison to 6 weeks with a 0.33 hazard ratio, an area under the curve, very interesting and significant difference in terms of overall survival. Different doses of sunitinib were assessed because there were some trials that were analyzing PET images, and at 2 weeks of rest, there was clonal repopulation and increase of activity. So what they did is to assess 37.5 milligram dose, daily dosing without stopping in for any weeks, observing a significant increase in progression-free survival. And in spite of this, FDA and European entities authorized today both dosages, 50 milligrams on, 2 weeks off, or 37.5 milligrams in a continuous fashion. This is the GRID trial or GRID study, analyzed imatinib, sunitinib versus regorafenib with gradually escalating dose up to 160 milligrams per day, starting at 80 milligrams per day. Primary endpoint is PFS, and we can see a statistically significant difference between two things for regorafenib, 4.8 months versus 0.9 months in the placebo arm, with 0.27 hazard ratio. As I said, this has allowed the global survival data. Regorafenib was established as third line of treatment. What are the implications of progression-free survival and different lines of treatment? Imatinib is a still first line of standard treatment and first line standard of care, but there are certain mutations that are known that will not respond. 10 to 15% of the patients will not respond because they will be not sensitive to imatinib, and this is related to the mutations in succinate dehydrogenase, and also patients that have other hereditary diseases such as neurofibromatosis type 1 or mutations of BRAF or RAS. And for this, we have preliminary data, phase 2 trials with not too many patients. We can see here regorafenib demonstrated clinical benefit in 6 out of 6 patients that have this mutation, PDGFR alpha or wild type for GIST tumors. And also this drug was of benefit in pediatric patients that had not responded or had progressed with imatinib, and they had a high rate of mutation of FDH gene. There is also patients that develop resistance as a secondary fashion. This is not primary resistance, and this is related to mutations in the ligand binding site, different sites of that or those patients that could have mutations of juxtamembrane domain or different domains from tyrosine kinase. Crenolanib, in this sense, is a specific inhibitor of FLTTR, PDGFR, and KIT. It's active against the DH42V mutation that comes from PDGFR alpha. And this study, phase 1, phase 2, showed efficacy that was very promising and also safe drug. And this motivated the GIST trial, phase 3 trial, crenolanib versus placebo for those patients that have the D842V mutation for PDGFR alpha, and primary endpoint, progression-free survival, and secondary endpoint, overall survival. And avapritinib is a selective inhibitor of PDGFR alpha, and for KIT mutations, and also for the D842V mutation, and also a not very frequent mutation of the exon 17 of the KIT gene. The phase 1 trial, which was called Navigator, enrolled patients with mutation exon 18, PDGFR alpha, and those patients that were progressing to 4 or more line of treatments. And the response rate was 86% for this specific mutation. And for benefit rates, specifically, that were very interesting for those patients that had the exon 18 mutation, those patients that had progressed to 4 or more lines of treatment. The safety profile was favorable, and this produced a rapid approval from the FDA in 2020. Avapritinib. The development of phase 3 trial, the Voyager trial, that recruited patients that had failed to imatinib and 1 or more TKIs that were different from imatinib, and they were randomized to 2 arms, avapritinib versus regorafenib in 1-to-1 arm. Primary outcome was progression-free survival, and secondary outcomes that you see overall ORR, overall survival, and quality of life. The trial was negative, nevertheless. Progression-free survival was, PFS was 4.2 months in comparison to 5.6 months in the placebo arm, and response rate was 17% versus 7% for regorafenib. So FDA withdrew the approval a few weeks ago for avapritinib. Ripretinib is selective KIT inhibitor, last generation of the PDGFR alpha. It acts on a specific site in a very particular pocket, which is responsible of the kinase going from an active state to an inactive state. That means it's a switch control inhibitor, and this phase 1 trial, efficacy in 4th line of treatment, overall response rate of 9%, and median progression-free survival of 5.5 months, with a safety profile that was favorable. This originated 2 phase 3 trials, Invictus. These patients had previously treated with imatinib, sunitinib, and regorafenib, but had progressed, were a 2-to-1 randomized fashion, ripretinib versus placebo. PFS was primary outcome. The other trial was in 3 patients with progression or intolerance to first-line treatment with imatinib, trying to improve the benefit of ripretinib in first line of treatment. Initially in treatment, 1-on-1 versus sunitinib. Primary outcome, progression-free survival. We have results from the Invictus trial published last year, where we can see PFS, median PFS 6.3 months versus 1 month in the placebo arm, favoring ripretinib with a 0.15 for PFS of hazard ratio, and area under the curve that is very impressive, especially in these patients that had already failed in the 3 lines of treatment, and confirmed ORR for ripretinib versus 9.4 versus 0, and median overall survival 15 months versus 6 months in placebo. So this gave origin to the approval by the FDA. In May last year, safety profile was favorable, with certain things that we have to take into consideration, and we will speak now. I'd like to say the tyrosine kinase inhibitor, and for compliance, this results in a rapid clonal repopulation, and we will be given TKI's therapy for a longer period of time, and management will be very different from IV chemotherapy. Compliance in this treatment, we can manage toxicities. And this is an old therapy for us. We can manage it very well. And this is interesting in terms of management with sunitinib, considering that mucositis and hand-foot syndrome quite often will require dose reduction. And it's important to monitor, as it states in the screen, thyroid function, blood pressure, and cardiac function with cardiac ultrasound. With regorafenib, recommendation is to start a third-line setting, such as the pivotal trial. Start with 80 milligrams and reach 160 milligrams daily. It would seem that these patients have better toleration in comparison to regorafenib, and it's important to incorporate the dermatologist in this treatment to monitor what is going on and everything that can appear, the palmoplantar or hand and foot syndrome, to monitor blood pressure and do a cardiac ultrasound at the time I started treatment with regorafenib. Even though this is in a scenario which is infrequent for a program surgery, it's important to stop treatment 4 weeks prior surgery, elective surgery, test TSH and proteinuria. In ripretinib, it's in therapy, it's important to incorporate the dermatologist from the start of treatment, especially because there are serious side effects and new malignancies, cutaneous malignancies related to this drug. Hypertension is much more frequent than with sunitinib and regorafenib and imatinib. Cardiac dysfunction also can appear as a risk, and it must be taken into consideration. Test with dermatologists, looking new cutaneous malignancies, to do a baseline cardiac ultrasound, and stop treatment at least 2 weeks prior to any type of surgical intervention. Ripretinib, sunitinib, and regorafenib, with all these 3 medication testing and blood pressure is relevant. With regorafenib, hypertension could be more frequent, so it's important to stop the drug if the hypertension is severe and restart with reduced doses, or discontinue on a permanent basis if hypertension is difficult to control or manage. To conclude, Invictus showed that ripretinib is in the 4th line and beyond, benefited overall survival. 15 months of ripretinib versus 6.6 months of placebo. Those patients that received ripretinib after placebo experience and were close to the ripretinib arm experienced an improvement in overall survival of 11.6 months. Crossover was permitted in the pivotal trial. The safety profile of ripretinib is actually quite similar to imatinib, but please take into consideration the higher probability of toxicity, cutaneous toxicity, the probability of developing new cutaneous malignancies, and take into consideration that alopecia is a higher degree, up to 40% of the patients, and is something to take into consideration when treating these patients. Management of side effects. I see. This, with sunitinib. And thank you for your presentation.
Y quedo abierto también para
¿Cómo está la
Al
traducción?
aire, Satan.
¿Mm? Buenas tardes a todos. Muchas gracias por las
Good
excelentes.
afternoon, everyone. Thank you very much for the excellent presentations. Before we start, I'd like to confirm that translation was working. Hello, everyone. If you are listening to me, I am the translator. You have to put English in your screen. Testing, Dr. Saul.
And Dr. Fernandez, I don't know if the translation service is working well.
I'm not aware that I'm hearing any translation.
I am speaking in the English Can you hear me?
Okay, so
Listo, la traducción no funciona. No se les explicó a los... Ahora me están pidiendo que traduzca al español, me cambio de canal.
Thank you all for these excellent talks. I think everyone have been introduced except Dr. Fernandez. Dr. Fernandez is the medical director of hospital, Syro-Libanese Hospital in Brasilia. He also did a gastrointestinal oncology fellowship at MSK. So he also was a Dr. Salt's fellow. So they know each other pretty well. I would like to start with the rectal cancer questions. I think both Dr. Salt, Dr. Solea, and Dr. Fernandez could address this question. What happens when we have low rectal tumors and they are not that advanced? Is TNT also an option for those patients in order to avoid the surgery? I feel sometimes that we are looking for a complete clinical response in more advanced tumors, and we are leading patients with early tumors directly to surgery. So what do you think, for example, for a T2 and 0 rectal tumor that is very low? Is TNT also an option for those patients?
Yeah, I think that's a very important question. The short answer is yes. I think we're all learning to appreciate the importance of avoiding a permanent colostomy and an abdominal perineal resection whenever possible, as long as the patient is motivated to pursue that course. And so we certainly have patients with some relatively early stage but very distal tumors where we have offered them total neoadjuvant therapy in the hopes of achieving a complete response and avoiding surgery. And while, of course, nothing in this business is guaranteed, the success rate is reasonably high, and the complete response rate is somewhat higher in the earlier stage tumors.
I think can you hear me? Yeah, it's okay.
Yes.
Just a quick comment. I think it's a reasonable option for sure, and I think the information for the patient is the key here. So you just have to let the patient know very well that if a T2 with a surgery, he will have 95% chance of cure, and with TNT, we will still have to do a surgery in half of the patients, even in a T2 and 0. So I think to do a good overview of the possibilities for the patient is a key point here, and there's for sure a good option.
It's a very good point, Gustavo. There's no question that surgery is the default position, the standard approach, and the purest method to maximize the chance of cure. But what we're getting more and more into as we're getting more comfortable with the idea of non-operative management across the board in rectal cancer is shared decision-making with the patient, helping the patient understand the relative risks and the relative benefits, and working with the patient to figure out what is going to be the better choice for that individual.
And what do you think, Dr. Soler? I know that you like short course radiotherapy very much. For example, if we have these low-lying tumors and it's not that advanced, and you are doing TNT just for the possibility of a clinical complete response, how would you proceed? Or would you consider this option?
Yes, of course. After a good conversation with the patient, letting him know the risks associated with the non-operative management, I would agree to go for TNT. In our experience, a short course radiation therapy and FOLFOX for 9 cycles would be our approach. Since this is only a T2-0, I would expect a better complete response than the one reported in Rapido trial, because in Rapido trial, the patients had more locally advanced tumors, and they still get a 28% pathological complete response. So I think it's a good option for the patient if he knows the risk associated with this approach.
I find it very interesting to hear you say that, and I agree with you completely. I think it's important to point out not everybody does, and some of my colleagues at Sloan Kettering, Dr. Garcia Aguiar, who I don't think is on the call right now, has concerns that either short course has less proven track record in non-operative management, or that as we, and some of my radiation colleagues feel that as we get to the more distal tumors, the potential for long-term toxicity is greater with short course. I'm not convinced that those are the concerns, and I'd be curious your thoughts on that.
Yes, in my presentation, I showed 7 of the 8 randomized trials that in one of either arms, it was short course or long course, and long course, it was not better in any trial, in any outcome. So I think that short course is at least as good as long course radiation chemotherapy. So I think that to give a longer course of radiation is a waste of time for the patient, and I would think that it's better to go for useful chemotherapy, oxaliplatin-based chemotherapy earlier, and that is after short course radiation therapy, better than long course.
Great. We have a question from the audience. They are asking what's the best approach for TNT, for example, like it was done in the Polish trial with a short course of chemotherapy, like 3 cycles, or something more like institutional databases, for example, 8 cycles of FOLFOX, or more than that, like in Rapido trial, 9 cycles of FOLFOX. I know that there is no answer, a straight answer, but what do you think it would be the most appropriate regimen nowadays?
Anybody else want to take that? I'm happy to share some thoughts.
Go ahead, Stouts.
So I think it would be presumptuous of any of us to say that there's one right answer. So there are a lot of variabilities. I will tell you my personal feeling. I am very comfortable extrapolating the data from the IDEA trial in colon cancer to rectal cancer. And in that trial, 3 months of CAPOX was essentially as good as anything else we could give patients. And 3 months of therapy has a whole lot less toxicity than 6 months of therapy, any way you look at it. So I'm really very comfortable recommending to my rectal patients that as long as they are able and willing to take the CAPOX regimen, that 3 months of that therapy, 4 courses, each course being 3 weeks, is sufficient. And that's in conjunction with either long course radiation therapy with concurrent capecitabine or short course radiation. And I agree very much with Dr. Soleil. I personally favor the short course in most circumstances.
Yeah, I don't think we have a best regimen, but we have a best evidence. I think Rapido trial is the best evidence we have. So that's the point. I completely agree. And 3 months of chemotherapy, it's okay.
But as I mentioned in my talk, I don't want to get too hung up on the issue of whether radiation first or chemo first is the answer. And I don't think we know that answer. We have some data that favor one, but a lot of reasons to think about giving chemotherapy initially in a highly symptomatic patient, because the symptomatic response can be so rapid.
Dr. Souts, any patient for a triplet as a FOLFIRINOX as a first regimen?
A lot of people are interested in FOLFIRINOX. I'm not a big fan for a few reasons. 4 of the reasons are the 4 clinical trials done with irinotecan that are negative in terms of the adjuvant setting. So we're counting on an awful lot for the interaction with irinotecan and the platinum to move it into the beneficial area. But the C89803 trial, the ACCORD-2 trial, the PETAC-3 trial, and then Mark You Choose trial in resected liver metastases all showed no survival benefit for adding irinotecan to adjuvant therapy. If you've got a big, bulky, symptomatic tumor and a very fit patient that you feel can tolerate it, I suppose it's a consideration. There are definitely groups that are interested in that from a research point of view. I'm not satisfied that the data make it part of routine standard care.
Great. So maybe now we can switch off to anal cancer. Dr. Richelman, you presented both the French trial arguing that MDCF could be the best option with a high incidence of a complete response, but the only randomized trials is the one with Interact comparing paclitaxel carboplatin against cisplatin and 5-FU. What should we do in clinical practice? Can you present your algorithm?
Thank you, Sebastian. Well, you are right that the only randomized trial is the Interact, but we have to remember that it's not a formal randomized trial in terms of statistical comparison. It's a pick the winner trial. So although it is randomized, we still have the DCF data. Well, it's hard to compare them both. It looks that DCF is more, I would say, it's more effective apparently, and more toxic as well. So what I do using the evidence, I tend to offer carbotaxel for most of patients. But if I have a patient with high volume disease that really needs the response rate, so let's say a patient with high volume disease in the liver or widely spread bone metastasis then with pain, I would go for DCF. That's what I do. But there's no right or wrong answer here.
Could I add one additional potential right answer, which we're very fond of at our institution, which is the FOLFIRINOX, exactly. That the study that compared cisplatin 5-FU to carbotaxol really stacked the deck, because that cisplatin 5-FU regimen from the 1960s is about the most toxic way we could ever think of to give those drugs. And when we turn it around and give those drugs in basically FOLFOX with the oxaliplatin taken out and 40 per meter of cisplatin over 30 minutes given, it's extremely well tolerated and quite active. So I couldn't agree with you more that we have no one right answer, but because of my sense that it is in many people the best tolerated of those 3 choices, it's one that I often use. All 3 are definitely appropriate.
Great. And just to add, I tend to use carbotaxel administer D1 every 3 weeks. I don't do it weekly. We're just so much used to do this in other GI cancers, and it's more convenient to patients to come once every 3 weeks, especially now during the pandemic. So just to add this.
I think that makes perfect sense. I don't think the schedule is critically important, and going with the schedule that you're comfortable with, the schedule that's more convenient for patients, makes perfect sense to me.
Yeah, we are doing the same. I don't know, maybe we can move on to the GIST module. I don't know if there is a question for Dr. O'Connor.
El micrófono, Juan Manuel.
Yes, thank you, Sebastian, for your moderating this session. Let me move on to the last part of the comprehensive gastrointestinal session. Thanks, Dr. Mariano Dioca, because it's a very comprehensive, extensive review of the GIST in metastatic treatment. So my question is, because
we have some doubts about genotyping or mutational profiling in GIST. So my question is, in your experience or in your opinion, what is the best moment to perform this genotype before adjuvant? Because you know, and you showed some resistance and mutation to the imatinib. So before the adjuvant, before or after the first line, second line, what is your approach from a practical clinical view?
Thank you very much for your question, Juan. It's very interesting. As a matter of fact, we have some different situations because, as you know, I work in the public system and I also work in the private system. As a matter of fact, we should have the mutation and profile at the very beginning before deciding an adjuvant treatment, because there are some you have some decisions to make, and it's better if you have all the molecular panel before you decide an adjuvant treatment. In the public system, the molecular profiling for GIST is not available, as you know, not here in Argentina, and so it's very difficult to have in the adjuvant setting. So every patient that have some risk of recurrence are gonna get adjuvant treatment without the molecular profile. In the metastatic setting, first line we are going to move on first line without the molecular panel, and only if you have a patient that is progressing rapidly in the first line, we try to have the molecular profile. In the private system, I try to have the molecular profile when I am going to move to first line treatment, not in the adjuvant setting.
Okay, perfect. Thank you, Mariano.
Thank you very much.
Okay, I think they were all those great answers. So thank you very much for sharing those answers with us. And thank you very much for your participation in this rectal cancer and GIST session. So I think we can end the session for today. So I hope to see you all live next time. So thank you very much.
Gracias,
Take care, everybody.
Thank
Thanks.
you. Bye-bye.
Gracias.
Gracias.
Hasta luego.
Hasta luego.
Gracias.
Ciao, ciao.